We have a little more than 10 minutes of time for discussion.
I have a couple of, first off, thank you. Those were both excellent and inspiring and make me hopeful in terms of writing Bright Futures, which tries to then take this into practices. But here are my dilemmas, and these are not critiques because you were very good at elucidating this for me, but I want to drive it further. First, the concept of primary care means a lot of different things. A lot of children don't have primary care, or they show up when there's a problem, but you never see them for that ongoing well visit. Second, I think that people still have this Norman Rockwell sense of primary care as being, one child with one clinician, and you sort of refer to that about the strength of that doctor said, come back for the acne check. I get that. Okay, but so much primary care now is one child or family related to a clinic. And that clinic is I sense in many communities, less the people and more the building. And I don't mean that in a derogatory way, it's just where our profession is going. So one of the difficulties that I have in understanding how to make recommendations for implementation is what exactly primary care means. And John, you were very helpful in terms of pointing out the cost piece, because my question is, the question I was evolving halfway through your talk was, what happens when the study people go away? I mean, I think Ellen Perrin's study is phenomenal. But what happened when that research person who helped the primary care doc do those sessions, when that money went away and that went away? So if you could both, sort of talk a little bit more about the implementation piece, that'd be a huge help. Sorry.
Okay. So I haven't thought lots about the issue, but clearly, how do you bring parenting practices into primary care that extends all the way on up into adolescence is just really tough, because those are really quite different models. Now, on the other hand, my colleagues at the Oregon Social Learning Center, John Reed, would always say, I know, but the mechanism underneath is pretty similar, the driver in there. So it's not like they're totally different. They're all dealing with parent mediation. Obviously, it's different for different developmental areas, as any of us know, as our children passed into that pernicious period before they got out of our house, namely the adolescence. But it's, so I think that's a really tough cost issue. The other thing is, the good news is we have so many parenting programs. The bad news is we have so many parenting programs. So there's going to be selection that will need to be done. And I believe that we will need to develop some sort of decision support tool that will allow primary care practices and associations deal with these issues of choice in terms, and they'll have to probably subdivide it in terms of some sort of severity level. There will clearly, I believe, that there will be many kinds of disorders or of severity that will need to be referred out to specialty care. It can't be thoroughly. So I'm not an economist. I just note here that nobody was talking about cost, but then in most efficacy trials, that's been true. The problem is that cost almost always needs to be considered even from the start, I believe, in these interventions and innovations. Otherwise, we will not find a way to use them. But I don't have anything more specific to say than that. Joan?
Yes, you're absolutely right. I guess I can speak more readily about my own trial as compared to the full meta-analysis, where I don't know as much. But several of our clinics, which were very diverse, we were in 5 different healthcare organizations and lots of different clinics within them. Really, the kids related to the clinic. The doctors changed, and I don't know if it was the receptionist who was stable, or they were homes for the kids. Some of them really felt like health homes, even though this was done before health homes became a very prominent kind of idea. But for our kids, they felt like health homes. And some of them were academic medical centers. One of our clinics that was very much, I think they related to the clinic versus the doctors, was one in a kind of, I don't know what you call it, Ventura County, Mary Ann, Mary Jane, what would you call that? Like rural area. We had a lot of farm workers' kids in there. So they really poor farm workers' kids, they related to the clinic. So I really do think that these intervention models, at least the WIPIC depression treatment model, was tested across a range of these settings. And I'll have to say that, which I didn't say, is that, we actually found some data that suggested that the collaborative care model might be effective for reducing health disparities. We had stronger effect. We had a very large minority sample, and they really did benefit. And the effect was a bit larger in that sample. So I'll say that. So I think that these approaches do work with a clinic-based treatment, because, well, you probably know better than I, but I think when kids relate to the clinic as their home, any doctor there feels, unless they don't like them, feels like their doctor. At least that was my feeling being in the clinics. And then the second issue about cost is a very important one. And you have to remember that in the literature on kids, we don't have that much data on cost effectiveness or costs, even in the efficacy trials. And I'm feeling a little defensive because I didn't do cost analyses, but I have the data. So if anybody has the money, I will try to look at it. We ran out of money. But I personally feel like it might almost be too early to do a cost effectiveness analysis, because our results are always weaker in an effectiveness trial than an efficacy trial. And while the data on costs are important, I think that the models incorporated the idea of addressing costs. So in the larger Partners in Care trial, which really had the power to analyze costs, they found that the treatment was cost effective, and that that integrating the care didn't actually lead to more visits. It just led to different kinds of visits. So I think that that's the issue. But you're right, we need to look at costs.
Let me see if we can get, I know we're going to run out of time in here, but I'd like to get some questions in, please.
Yeah, I just have a quick question about the meta-analysis. In your slides, you showed that there is less of an impact on substance use disorders when looking at the integrated care. I was just curious if you could share some thoughts or hypotheses about why there's a smaller impact there and why you saw that in your study.
I think it's harder to change in that age group. They want to use substances. Their friends are using substances. We used, those trials used mostly MI, motivational interviewing approaches. I think it's a harder thing to change, and it's harder to show robust effects within the context of the meta-analysis, which weights and all of that. But remember, the P-BERT smoking cessation study worked.
Shep?
Really pregnant presentation. I say pregnant because we're talking about the developmental course of bringing behavioral health into actual work with children and parents and so on. There are 2 or 3 issues I think need to be commented on that would join this discussion with yesterday's discussion, and with an IOM report that Kelly Kelleher brought to our attention that suggests the integration of primary care with public health. So the question of site and how many people really have primary care physicians out of the denominator is a changing scene also, with ACA giving many more people entry into primary care possibly. But the fact of the matter is that we need to think about the denominator as well as the people who come to primary care. They're a sample of unknown characteristics of the people in a particular circumscribed community. So where is the rest of the denominator? Well, the rest of the denominator is in fact registered in school. The school has a catchment area in which these primary care sites exist. Joining the primary care site with the denominator, with the public health perspective, can be done through including schooling in our structure of healthcare, health, education, and welfare care, as Oviedo Colpabi tried to name it back in Eisenhower's days. We're talking about, in other words, maximizing the integration of primary care with community, with its social, political, cultural characteristics, but defining the denominator so that we understand what the population and their context is in which we're doing the work. Schools joining in as part of this would be an essential element, and we talked about that a great deal yesterday. And I think if we put today's conversation in the context of yesterday's, we would be talking about a developmental life course system with human services more broadly, and this is a key component. This work is germinal and has to be done, and now we have to provide a context for understanding where it fits.
Thank you. I'd rather see if I can get a couple of comments in here. We will be following up with a breakout immediately after this one, so I think we can give some time for that one, please.
Hi, I'm Terry Stinson. This was terrific. Just so important to be bringing this work forward. I guess one of my thoughts as you were talking about this is that we have this great evidence that you're providing that we have these small effects, despite the fact that the interventions were so diverse. I mean, it's almost like if you do almost anything that relates to behavioral health treatment in primary care, it's better than usual care. It reminds me of the fact that most kids who come to us never access anything. 85% of kids with mental health needs really never get any kind of service. So something is going to be helpful, more helpful than nothing. And the other thought I had is in reaction to Joe's comment about what do you do when the people leave the group, and it's been my impression, and I think that there is some data to support the fact that when behavioral health professionals come into a primary care setting, that it changes the skill level and the attitudes of the providers who are there. And so you really do change the climate and the culture of the clinic by introducing behavioral health skills. And I wondered if you could comment, if you have any data from your own studies that would relate to that.
Yeah, I agree with you. Yeah, but I do want to say one thing. It wasn't the case that all of the interventions worked. And in looking at them, and this is really where I think what you're doing is so very helpful, the more fine-grained analysis of the individual studies. So I think our talks kind of went together well. Good job, Marianne. But the ones that seemed to be effective were the ones that were evidence-based, Incredible Years, Triple P, depression treatments, David Kolko's collaborative care. Those were the ones that really did have the effects. And the ones that were, a little bit less established, I think were not quite as effective. So I do want to underscore that we really do need to make sure that what we export is evidence-based and that we are tracking our outcomes. But your point's very well taken. Yeah. Thank you.
Let me see if I can get two more questions in.
Laurel Leslie, pediatrician at Tufts Medical Center. A couple of thoughts that I had listening to what John was saying. It seems that Larry Wissow's intervention is really about how you communicate with the families to be able to then move them to the services you need, which is exactly the kind of thing a primary care provider can take on. The services then and how those get set up and integrated with what family needs becomes important. And I'll just raise a couple of other issues that have surfaced, but the kids that are having behavior problems that are over the age of 5, you don't want to be pulling them from schools. And yet when our primary care office is open, right during the school time, it's very hard to find people who are willing to see kids in the late afternoon, late evenings, and provide services, both in primary care as well as in mental health. And so what do we do about those issues? And the other thing is I sit next to Ellen Perrin and Chris Sheldrick. They had a big challenge in the inner city This worked great in suburbs, and parents wanted to continue the programs, et cetera. But you have parents who either aren't working, who are in charge of their own life and can make a decision about taking time off. When you get to the inner city with people who are working 2, 3 part-time jobs trying to keep things together, or very stressed families, I think we need other models. And I would agree with Shep that that's when we think about going into the schools or going into workplaces or wrapping around in other ways where we're building off of primary care, but we're moving into the community, into the public health systems.
Thank you. I didn't hear a question, so we'll just go directly to Mary Jane.
So great presentations. I had 2 brief questions and then a bigger field question. One, there was a big discussion at dinner last night about, because we heard so much yesterday about pediatrics, and this morning you talk about it as primary care, and in fact you distinguished and held out as separate family medicine. If you could comment, like, how do the studies in pediatric differ from primary care, differ from family medicine? The second, given this huge issue, neither of you talked about uptake rates. And we know that if we look in these preventive interventions in community settings, maybe you're getting uptake rates maybe from 3 to 30%, being really generous. What was the uptake and adherence in these trials? And the third is, all of our data are focusing on relatively small trials with basically, maybe you have 14 sites, but it's our colleague from Aetna who has hundreds, maybe hundreds of millions of people and hundreds of clinics which are going to have natural, huge variation. Where are those data? How are we going to link to learn from what is? Because there's got to be a lot of information in what's going on currently nationally.
The categorization we included in our search, family medicine, adolescent medicine, I think that was, so we tried to cover not just pediatrics, but all the way on through that 0 to 18. What I stumbled on is what to do with those studies that are out in the public health, maternal and child health. Because that's I think we should include them. I think that's part of the primary care system, but it's certainly not integrated into what one usually thinks about primary care. I think the hit rate, there was nothing in this, I mean, they clearly said, they reported on what was their flow diagram, no question about that. And it was pretty good in some, I mean, there were a couple of them that had most of the sites and most of the docs signed up for it and practices. But what we really need there is some kind of work that thinks about that issue about how do we get out to a much larger so that we can have the public health impact with that. And you also worry about whether there's such a selection factor that you can't have a very large public health impact because you're not reaching the kids. You know, what Laurel was saying is that Ellen Perrin, they had some problems down in really tough areas and worked out much better in the suburbs. Now, I do think that we have a huge opportunity that we'll be forced to use with regard to technology. Mark, you've done work on PCIT at a distance. One can do many of these parenting interventions are actually quite well done in group settings, which takes down the cost enormously. You can do that with new technology. So I think there are I think your point about Aetna and the really big systems is absolutely apropos. We've got to see because that's where you can get a much larger impact on this. And potentially you can solve some of the cost issues as well. Good points.
Okay, so number one was pediatrics versus family medicine and other approaches. we were in Youth Partners in Care, we were across both. And there are differences. You know, one of the things that we noticed was in family medicine, the doctors were much more comfortable prescribing antidepressants. I mean, you know, so I think that your questions are really important. I don't have an answer for it. It really falls in John's point about implementation and looking how that varies, and really having a case study approach, I think, as you enter every system to optimize that system, which I think gets to your point as well. And then the other point, which I think is a really, really, really important one, is about uptake. And what I noticed was that the studies that really used an effectiveness model, where the therapist, the mental health team were paid by the practices versus the studies, had much lower uptakes. You know, it was really integrated within the practice system, and I think you were right, it's around 30%. It's not very high, which is why the effects are fairly weak in the effectiveness trials. And as, like, if you look at the Youth Partners in Care trial versus the ROAD study, where the therapists were hired by the study, there's a big difference in uptake. And, you know, I think that accounts for some of the differences in outcome, although both yielded effective outcomes. And the third one was, what was the third one?
Where are the data from the big systems?
Oh, yeah. I wanted to say something in response to Shep's point in respect to that, which is that, you know, a lot of kids are not in primary care and are in school, and there are plenty of kids that are in primary care because they want birth control and they're not in school because they've dropped out. So I think that what we need to do is have a very big systems, heterogeneous approach to catching the kids everywhere, using our internet systems, because, you know, just in the past 10 years, the difference in the amount of internet use the kids have. If you ever watched a kid sitting at a restaurant with their parent, they don't talk anymore. They're all looking at their phones. So, you know, I think they're important points.
I'm going to move this to a break, a short break in here, and I know that we've got rooms outside that people will go to on this one, but, and then we will get back to these same issues. So I know other people wanted to talk. We will get a chance to do that. So thank our speakers today.